Welcome, everyone. Good afternoon. Good afternoon from all over the world. I think this is always a challenge for the EMS project handling this kind of webinars. So today we're gonna sharing patient safety on EMS services, and we have four speakers for this meeting. They will come from Portugal and Spain and Israel. It will be a huge opportunity to share some knowledge and come along with this discussion at the end with all the presents on the meeting. So for me, as a moderator, I'll just start to presenting our presenters. We'll be handling four presentations. The first one will be improving patient safety in pre-hospital emergency care in Portugal. It will be handled by Ândrea Figueiredo. She's a specialist nurse, head of patient safety community from INEM. The second one will be handled by Paloma and we'll be sharing about building a culture of patient safety in pre-hospital emergency care, the SAMUR-PC patient safety system. Paloma is head of unit of quality assurance at SAMUR Madrid, Spain. The third one will be handled by Joana, Sofia de Silva Maia, is a public health medical doctor from INEM as well, and she will bring to us the infection prevention and control in pre-hospital emergency care. As well, for the fourth presentation, the invitation was for Israel, for Tomer Kaplan. He is a KA Patient Safety Department Manager from NDA Israel. So this is indeed the four speakers that we'll have this afternoon. Good afternoon to everyone. Thank you for coming and thank you for sharing all the knowledge you bring to us. Just let me share to everyone who's here, will be a specific space for some discussion at the end. So in this first step, we're gonna stay with the speakers and hear what everything they have to share with us. And they will be, the first one will be Ândrea Figueiredo. Good afternoon, Ândrea.
May I interrupt you, Joe, just for a quick project introduction?
Okay, sorry,
Michelle. As Joe introduced the speakers so fine, I don't want to steal a lot of time, but I've seen in the registration that we have a few new partners here. So just let me talk a little bit about it.
Okay.
You should all see my screen and presentation mode now. So
yes.
The project is called KnowEMS, and this is a co-funded project by the European Union. And my name is Michelle Thompson. I'm from the UNITA, and it's not only the UNITA, it's not only INEM. We have a few more partners in here. For example, from Romania, DSU. Then we have from Israel, Magen Adom, the colleagues from Portugal, INEM, the colleagues from Spain, SAMUR-PC, and colleagues from France, SFMC and APHB, who are building the consortium for this project. And the context or the background of the project, another project which was called No Fear. And the main objectives of No Fear were to create a long-lasting community of practitioners interacting with a network of suppliers and academia, to integrate priorities of standardization and support quick wins and practical short-term results, and to implement a transactional dynamic portal providing fora, a catalog and marketplace and flexibility to address new threats, as this whole project existed during the pandemic. And there was very clear that there was no quite why KnowEMS was started. And what we're doing regular webinars on very interesting topics. For example, past topics have been management of sepsis, helicopters in EMS, stop the bleed, triage in pre-hospital and hospital setting and mass casualty incidents. And our next and sadly for now last webinar will be on the 11th of December, and the topic will be AI and medical emergencies. And if you now hear one of those topics and think, well, I've missed that, I want to see that, all recordings are on our YouTube channel. I will post this in the chat afterwards as well. Scan this QR code, follow us on our YouTube channel, and then you can have a look at all this other different topics and very, very good speakers. Thank you. And now I give the word back to you.
Thank you, Michelle. Thank you once again. Ândrea, I think you are already ready, right? So
yes, I am. Thank you, João.
let's go.
Thank you. I will share my screen. Okay, I think you are seeing.
Yes.
I will speak. Thank you. I will speak about improving patient safety in the pre-hospital emergency care in Portugal. I have to say first that I have no conflict of interest in this presentation. First, to a little bit of context, in Portugal we have an integrated medical system, and the National Institute of Medical Emergency is an organization within the Ministry of Health responsible for coordinating the operation of this system in mainland Portugal, in order to ensure that accident victims or victims of sudden illness receive prompt and appropriate health care. The main tasks of INEM are to provide emergency medical care in the field of the incident, assist during the transport to the appropriate hospital, and coordinate the different actors in this system. So it's up to us to say what is to do and what is the best practice in the patient safety in the pre-hospital also. So that's why the INEM created a patient safety committee in 2013, and that it's still working, and I hope it's an ongoing project because it's very, very necessary to this kind of work. The INEM patient safety policy was created in 2030, as this area was a gap in the Portuguese emergency medical system. The challenge was to carry out the diagnostic and survey needs, identify priority areas of action, and find available national and international solutions so that we could transpose and adapt them to our specific context and reality in the pre-hospital care in Portugal. To address this, we based our work in the international patient safety goals, and we based our work also in the guidelines from the WHO about the patient safety and in all of the reports that the WHO annually publish. The National Plan for Patient Safety in Portugal is supported by 5 pillars. With the definition of several strategic objectives and respective actions and targets. And we use this plan also in our work in the Patient Safety Committee in INEM. The 5 pillars are safety culture, leadership and governance, communication, prevention and management of patient safety incidents, and practice in safe environments. So with all of this information, we establish as priority areas for action in the pre-hospital context in Portugal, the patient identification, the safe use of medication, the prevention of falls and injuries, the communication and information, the safe childbirth, and the incident reporting systems. So, the Patient Safety Committee from INEM planned interventions considering 5 main axes. One is the training and the awareness raising. And to address this, in INEM, we have a course that it's the pre-hospital patient safety course. We started that in 2019, and in 2021, this course become mandatory for recertification every 5 years. And until now, we trained around 1,020 and 2057 professionals from the pre-hospital field. and we hope to do more and more, and to become this course mandatory not only for the professionals from the INEM, but for all the professionals in the pre-hospital. I'm sorry. In this HEX, we managed to do several awareness raising actions, like in webinar format. We did it about patient safety in pre-hospital in a generic way, about therapeutic patient restraint in pre-hospital, about effective communication in pre-hospital, the ISPAR, about the medication lookalikes, and about the importance of the patient safety, the person, the patient safety, and also how to notify in the health information system that we use in INEM, and how to analyze and treat incidents in this system. Also, we do some information campaigns through posters, videos, and publications on INEM communications channels. In the governance and organizational management, we do meetings with the managers and the patient safety committee. We published a manual about patient safety in pre-hospital, and we already updated it 5 times, and we developed new guidelines and review existing procedures. About risk management, we have a system in our organization that is the health event risk management system, and we started the process of reviewing and updating this patient safety area for reporting. We established one new analysis group and new training to the experts to analyzing the incidents. We create also a management procedure about this notification in this system. So, and I forgot to say that since 2017 until the last year, we have more than 390 incidents reported in this system. We do also annual patient safety audits we go to the different ambulances and to the pharmacy and the warehouses, and we do also regular audits to the use of patient restraint procedures that jeopardize their safety and the safety of those around them. In the advisory field, we participate also in working groups and in procurements also. So some recommendations that I give you, I still have a few minutes. So we give some recommendation about prevention of falls and injuries, and we consider that all patients in pre-hospital are in a high risk of falling. We don't need scales for evaluate this. They are not applied in this context. We consider that all of them are in a very high risk of falling, and we recommend some systems for the adults and also for the child. Pediatric victims should be transported in appropriated pediatric restraint systems. Also, we did a study about this problem, and we discovered that in a lot of ambulances don't use this kind of systems. So we prepared a project called the Precious Cargo, the Pediatric Safety on the Pre-Hospital Move, and with this study, we prepared and published a technical guideline and evaluated different certified devices for safe pediatric ambulance transport available on the market. And this guideline is available to all of our partners in the city. We also give recommendations for the prevention of falls and injuries using the the stretcher and the chair, the transport chair. We also give a recommendation about the lookalike and sound-alike medication and high-risk medication with a guideline also. And we establish 13 rights based in the best scientific evidence. We use 13 rights in the safe use of medication in the pre-hospital also, and we give all of this information in our trainings. Our next steps are to create a technical guideline related to patient safety identification, applicable to all emergency medical services in the Portuguese integrated medical emergency system, work to the Directorate General of Health to include the pre-hospital care in the national patient safety technical guidelines, and increase the training on patient safety in the pre-hospital for our partners in the CM. To achieve the patient safety, we have to do a multidisciplinary work. We have to guarantee development of our safety culture, address the teamwork, the safe and informed communication, the safety, the risk analysis, and the quality improvement, and not to forget the clinical human factors that influence all the system also, and that are always present. The patient safety depends also the incident reporting and investigation center. So it's very important for us that everybody reports the different incidents, near misses or adverse events. Every system is designed to achieve exactly the results it gets. If you don't like the result, say change the system. This is our challenge for all of you, and keep calm and safety first always. Thank you. 12 minutes, I think.
That was perfect.
Thank you.
Indeed, very, very fast indeed as well. So Ândrea, thank you very much for all the sharing. I will invite everyone to get some questions on the chat. At the end, we'll be open moment for some discussion from everyone. So for now, I will call for Paloma from SAMUR, Spain, Madrid, Spain, to bring us something about building a culture of patient safety in pre-hospital emergency care. Paloma, you're there.
Okay. Good afternoon, everyone. Thank
Hello,
you
Paloma.
for... Hello, can you hear me?
Yeah, sure. That's
okay.
Perfect.
Okay, good afternoon, everyone. Thank you for attending this webinar. Today I will present how SAMUR Protección Civil has developed this internal patient safety system known as SINASEP to build a culture of clinical safety in the pre-hospital emergency setting, with the objective of ensuring that every patient receives the safest possible care, given that sometimes our pre-hospital environment adds extra pressure to the medical attention, like limited time, limited information about the patient, environmental hazards, and very rapid decision making. Okay, very rapidly, you all you know about this. Clinical safety is based on the idea that harm rarely results from a single mistake. Instead, adverse events occur when multiple system weaknesses align. This Swiss cheese model illustrates this concept. Each slice represents a safety barrier designed to protect the patient. and the holes represent vulnerabilities in training, communication, supervision, etc. When these weaknesses overlap, a pathway opens through the barriers and an adverse incident can reach the patient. So reinforcing each barrier through proper training protocols, monitoring, teamwork, etc., is essential to prevent harm and improve patient safety. So a little background from SAMUR. Before formalizing the SINASEP system, SAMUR already had a strong tradition of clinical safety, among which we can highlight the evidence-based operational and clinical protocols, senior medical and nursing teams supervising complex cases, hospital follow-up of critical patients to learn from outcomes, on a scene performance assessment and medical record audits, continuous monitoring of quality indicators, and dissemination of good practices through publication and conferences. All this was integrated into a structured patient safety program in 2010, setting the foundation for a long-term strategy. Finally, SINASEP SAMUR was launched in 2012. So SINASEP is our internal system for reporting and learning from incidents related to patient safety. It adapts the Ministry of Health national framework to the pre-hospital environment and is based on a learning-oriented, non-punitive model. Every report is submitted in a dedicated online platform that you can see in the slide. Since the very beginning, this system has had an evolution. In 2012, SINASEP was launched. An initial quality culture assessment was done, and the staff training began. In 2014, the first incident notification was registered in the platform. In 2017 and 2018, safety tips in SAMUR monthly newsletter was published, a communication campaign was conducted, and improvements in the digital platform were done. Later in 2019, the expansion of system access and greater dissemination of the achievements was done, and 2021 onwards, annual training was fully implemented, leading to a notable increase in reporting. This gradual evolution demonstrates a clear institutional commitment. So the main objective of this system is to improve patient safety by ensuring effective reporting, analysis, and prevention of adverse events and near misses. Specific objectives include promoting, of course, a culture of patient safety and ongoing improvement, identifying, analyzing, and learning from incidents, implementing preventive and corrective measures, ensuring confidentiality, independence, and non-punitive environment. And I have to say that in SAMUR quality policy, patient safety is considered a strategic priority. So every report follows structured processes. Incident report is submitted anonymously by any professional, then is analyzed by the patient safety working group using root cause methodology. This group makes recommendations for improvement, and the implementation of this recommendation are coordinated by the safety committee. Its purpose is not to blame individuals, but to understand what happened, why it happened, and most importantly, how to prevent it in the future. This process has already produced concrete improvements, such as changes in the maintenance procedures, updates in medical supplies and equipment, in-depth root cause analysis of sentinel events. For example, this year we had a critical incident consisting of a malfunction of a defibrillator, and implementation of a structured training in patient safety. So ultimately, the goal is to foster organizational learning. This slide only represents the incident reporting circuit, starting from the communicator, passing through the safety working group, and finally to the safety committee. So these three groups ensure independence and effectiveness. Operational staff normally is the communicator, report incidents anonymously through the dedicated platform I told you before. Patient safety working group is composed of 4 emergency physicians, 6 emergency nurses, 2 emergency medical technicians, all of them without managerial roles in order to guarantee independence. Their task is to analyze notifications and propose preventive measures. Their participation is voluntary. And finally, the safety committee is composed of responsibles from each department in SAMUR who evaluates the feasibility of the proposed measures and approve the final implementation. So this slide summarizes the 4 core actions areas of SINASEP. Training and professional development. We designed and implement safety courses that are fully integrated into our training program. External collaboration and leadership. SAMUR participates in external working groups, presents safe practices at national and international events, and contributes to internal risk mapping. Safety culture promotion by means of institution-wide awareness activities, and of course adverse events analysis, the voluntary use of SINASEP to learn from errors, ensure confidentiality and support organizational learning. So together, these 4 areas reflect how we promote patient safety across the whole organization. So regarding activity and results, across more than 10 years of operation, 882 cases has been analyzed. These cases generated improvements incorporated into training sessions, protocols, checklists, team communication, and resource management. Every single case has contributed to safer care practices. So let me close with a few key messages. Reporting is learning. Confidentiality and non-punitive culture are essential for honest reporting. Analysis plus prevention is equal to safer patients. Everyone contributes to patient safety, no matter what is the professional background of the notificator. Errors are humans, learning from them is professional. And the last one is my favorite. Technical skills is essential, but communication and teamwork save lives. So to conclude, SINASEP SAMUR is much more than a platform. It's a cultural change, a shared responsibility, and a commitment to excellence in emergency medical care. Thank you very much.
Thank you so much, Paloma. Very, very good learning lessons to kept. So amazing. Thank you very much. Now we'll have the stage reserved to Joana Sofia da Silva Maia for the infection prevention and control in pre-hospital emergency. Joana, are you there?
So hi.
Hello,
Yes,
Joana.
can you hear me?
Yeah, perfect. Go on.
Okay, so I'll start. So, like João said, my name is Joana Maia. I'm a public health medical doctor, and I'm collaborating with INEM. And I'm here in the regard of the Infection Antimicrobiology and Resistance Control Committee. And I'm here to talk about infection prevention control in pre-hospital emergency care. It's not. Oh, yeah. So the first thing that we want to talk about is the relation between the patient safety and infection prevention and control measures, because of course our other colleagues they work on the patient safety committee. So I'm working in a different committee, but this is also very related to the patient safety as well. So these IPC measures that we have, these infection prevention control measures, they aim also to break the chain of infection. And of course, if we break the chain of infection, we are making sure that our care is safe and high quality. So I also want to say that when we look at IPC measures, and we see here on my right that we have the epidemiologic triad, we can see that we have the agent, host, and the environment, that this is the triad to make sure that we can make an infection. You know, we have to have the three of them. But if you control the environment, we can regulate more the agent and the host interaction and make sure that that interaction between those do not result in unsafe care and infection that should not be there. So when we talk about these IPC measures, in breaking the chain of control, we are talking specifically about health-associated infection. So infections that are acquired in the hospital care, of course, are health associated. Before that's the term that we use, but now we know that all of other healthcare contexts is included here in the health associated infections. So even the transport, in the ambulance that we have, to the hospital, and even long-term hospices that we have, elderly people, that's also a health associated infection. So, and then we're going to see the microorganisms that are responsible for these infections, and you may think that it's going to be, most of them is going to be transmissible by respiratory agents, but most of them are also, are actually transmitted by the surfaces and the contact between, surfaces and the patients, and so it's not like airborne, like you may think, like most general people, general public thinks about it. So when we think about also these health-associated infections, it's very important to talk about the resistance, to antibiotics. And 71% of this resistance that we see in antibiotics is are constituted, by the health-associated infections. So it's a very big percentage of this, and 50% of these are preventable. So we can, provoke a lot of harm to the patient if we not control the environment and make sure there is not interaction, between the agent and the host. Of course, there are things that we cannot prevent, but there are things that is within our reach to make sure that is not going to have transfer and going to provoke further harm to the patients. And also I want to reiterate that this infection, we think, that's not very common, but it's one of the most common and favorable outcomes of the healthcare delivery. Is not, other stuff, is actually this infection that we're talking about. So we have a lot of IPC practice, to prevent these infections. But I want to focus, on that we have all of this, like the patient placement, and the infections risk of the patient, the hand hygiene, the respiratory hygiene and cough etiquette, and also the use of the PPE, controlling and the contamination of the environment and the equipment and the clothes of the staff. So we have a lot of IPCs to make sure that we do not provoke further harm, but at the same time, these are all of them are very basic, that things that all of us can do and improve to make sure that our patients and our professionals, are not in this kind of risk. So why am I talking about these measures in the pre-hospital care, right? So the pre-hospital care has specific challenge that we don't have in other places. So, for example, when ambulance go to to collect a patient, we don't know what kind of environment we're going to have. We don't know if it's going to be like a house, if it's going to be on the street. We don't know, like if it's a long-term care facility, for example, there are more risk on that environment than in other kind of environments. So this is all our uncontrolled environments, and of course is high stress and time pressure. Sometimes, not all the times, but sometimes we are doing stuff that is time sensitive, so we have to save the patient's life, and of course that's more important and more urgent than personal hygiene and contamination of the surfaces. But at the same time, not all of the care that we provide are time sensitive. So because of this, we have to have these measures instilled in our professionals to make sure that subconsciously they know what to do, and they will do it even when the high stress and time pressure is on. Also, we have a frequent patient turnover, with multiple contacts and surfaces, and of course there is increase of exposure risk. So if you have someone committed in the hospital, they stay in the hospital. If they mostly stay in the same bed, sometimes, in the duration of their stay. But here we have, within, some hours, we have a lot of patients in the same surfaces. So of course it's completely different, than having one patient in one bed for 1 week. The risk is completely different. And in terms of our infrastructure, we also have our infrastructures are very small. The ambulance, the surfaces are very constricted, in comparison, in comparison to the hospital care and other health care. But these are very crucial. These are very important to make sure that we protect the patients, because sometimes when they come to us, they already are in a vulnerable state. We don't have to provoke more harm than one that already have. So this is very important to talk about. And also our healthcare professionals, because we have, as healthcare professionals, we have our friends and family, and sometimes we go home and we don't, take the measure that we should, and of course we contaminate, and we don't want to also provoke harm in our personal life. And we also have cross contaminations between events that is very important to prevent, not only between patients in the ambulance, but even in the events of getting the patient and transfer them, to the hospital. And we also want to maintain the public trust, because, sometimes, people go to the hospital and they think, oh, I'm not going to hospital unless I'm really sick. And you can see that during COVID, for example, that people didn't go to hospital, even if they had strokes, because they were afraid of getting some disease. So we also want to maintain this public trust, because it's very, very important. And as a committee, we focus on our 5 main pillars. We tried to capacity building, so we tried to train all the professionals that we have in these IPC measures. We tried to develop and disseminate all the technical information that we can get, and we think it's important to the practice, of course, and even to the general public. We promote scientific activity. We monitor all of our activities, and then we go to Congress, international ones, national ones, and we present our results. We try to make publications. We are working on a peer review publication right now. We collaborate in epidemic surveillance of programs that we have, nationally and locally. We collaborate when, when is needed, but also we monitor these IPC measures in our activity. So I want just to share a little bit of our results that we do these audits in the IPC measures, and we can see that, you know, in terms of knowledge and the global quality index, we have an improvement because we have data from 2021, and we can see an improvement, you know, and we have a little decrease here in the resources. So when we noticed that, we decided, you know, to try to improve this. So we think that in 2025 we were going to be, you know, much better than we were before, hopefully. So we do these IPC measures, you know, we do this monitoring and these audits. And I just want to focus, for example, on hands hygiene, because you think it's very basic. So we think that everybody does. So we can see here that even if it's improving a lot, you know, between 2021 and now, but still, you know, the quality index that we want is 100%, you know, or 99.99%. So there's still a long way to go, you know, there's a really room for improvement here. So we also have some challenges, you know, like as a country, and, you know, because we have a very geographical dispersion of the country. So it's very different, you know, like the resources that we have of one part of the country and the others. And we have, like, our population in Portugal is mostly on the littoral side, you know, near the sea. So it's different, you know, it's difficult for us to have the same reach within the country. And we have all of the other challenges that are already presented. But I want to also talk about a little bit about our future projects, you know, because of course I talk about that we do this monitoring, and we do this monitoring so we can also have ideas and try to improve this. And for this, for example, we're trying to develop a hands hygiene audit. You know, this is like new things that we're working on, because we notice that something that is very, very simple that we can, you know, improve so much still. And, you know, this is going to be very impact, you know, for the patient's life, and also trying to continue to analyze the surface contamination analysis, because this is also the paper review that we're talking about. So we're trying to, you know, to continue this work and trying to do some comparison between, you know, the results that we had before and the ones that we probably have now. Ooh.
Joana, are you there?
Yes, I'm there, but my screen just went black. Can you guys hear me?
Yeah. We keep on hearing you.
Yeah,
Well,
but
the screen just stopped on future projects.
Yeah, but my screen just went black. Yeah.
Well, for us, the future stays on hold. So
yeah, I know, but I cannot do anything, you know.
Yeah, keep on talking. No problem, Joana. Take your presentation to the end.
Yeah, so I'll do it my presentation, but
Yep.
my screen is black, okay? So then you have to mute me
no
as
problem.
well. So yeah, so I also want to see, you know, besides the future projects, we also want to talk a little bit about what can we do to improve this the results that we already have. So we want also to focus on communication, you know, between institutions and also within our institution. And we also want to make sure, sorry, but I'm doing this by heart right now because I don't have a screen in front of me. And also we want to ensure that you know, there is a really clear communication between leadership and our healthcare professionals, and make sure that we try to continue these good results that we're having and trying to improve them even more. So, you know, small changes and simple changes create a big impact. So thank you so much for your attention.
Thank you so much, Joana. It was a good end anyway. Thank you, so much for the presentation. Good presentation as well. Thank you very much, Joana. We'll now take a place to hear Kaplan for NDA Israel. He's gonna share with us patient safety department. It's from patient safety department. So, Tomer.
Yeah, 1 minute. Hi, everyone.
Up to you now. Try to share your screen as well, just to double check if it works.
Wait, see that you don't see my do you see my screen?
Yep, perfect. Yep.
Can you see the presentation now?
Yes, yes, yes.
Okay. So hi, everyone. I'm going to present some of MDA quality assurance and patient safety activities. I'll try not to, what I try to do, since we only have 10 minutes, is to focus on some activities and less background. So it's a small department. It's actually, I'm the head of the department, but we have other, I would say, branches within the quality management or patient safety department. The first one is we have a medical call center, which supports the team 24/7. Whenever team has to consult with the doctor, they can call, they get an answer right away, and they help them make decision online regarding the treatment that the patient need to do. And in addition, the medical call center also does medical record audits. I'm going to refer to it further on. We also have regional medical directors, which are emergency medicine experts, doctors with very, I would say, rich experience in the past. Some of them still. We have deputy managers of hospitals. We have emergency department managers. So they're all very experienced, and they're all supporting at the end, everyone is supporting the stations or the regions of MDA services. With every region, we have 11 regions in MDA. It's geographically divided. So every region has a medical supervisor, and under him, he has the station managers, and each one of those roles have something to do with patient safety and quality management. I'll show it in a second. So if we'll go through the activities, of course, the publication and review of SOPs, guidelines, treatment protocols, and the part of the implementation of the knowledge and maintenance, which is, it seems like something I wouldn't say minority, because it's a key aspect of our work, but it's also very challenging since our staff turnover rates is very high. So keeping the knowledge and teaching experience is something that is very hard to do. So I think in patient safety, it's a key aspect of the patient safety at the end of the day. Of course, we do miss and near-miss event investigation, and we issue every month a patient safety leaflet. Usually, it's by a near-miss investigation with the conclusions and recommendation for better treatment. And every quarter, we issue a newsletter with a short part covering all the issues that were covered within the monthly leaflet. We also have a medical review system. I will present it in a minute. Field audits. We conduct research all the time. We have a large data bank, so it's important to have research. And also from every research we do, we try to optimize something within our service according to the results of the research we did. We always monitor, so we monitor common errors, number of reviews, online live monitoring, and quality indicators. I will show it later. And also technical barriers. I will present that later as well. So if we look at the medical record review, what we did is we built a pyramid approach. The medical review is done by also few branches. So as I said, we have the medical dispatch call center. So they're in charge of doing, there are 3 paramedics sitting there and a doctor 24/7 online. So they're in charge of doing something like, I would say, roughly between 50 to 100 medical record review per shift. Other than them, the medical supervisors are doing medical record reviews for selected, I would say, new paramedics or new medics, or sometimes the station managers themselves if they do shifts. So the medical supervisors are doing medical review for them. And at the end of the day, the station managers also do a medical record review, which they need to do 2 medical record review per month per worker or volunteer. And we defined the level of the, I would say severity, but it's not severity because it's a teaching tool. but the level of mistake that was found in the medical record, with 1 meaning it's a good medical record, there's no mistakes in it. 2, there was a mistake, but it's a minor mistake, and it goes on up to 4. And then since it's computerized, we have also a referring system. So once the review was done, it needs to be answered by somebody according to the level of the severity of the review. So if it's number 1, meaning it's okay, the report is okay, then only the team get an alert that his record was reviewed and everything is okay. If it's number 2, the team and the station manager get the alert, and the station manager has to talk to the team and record what action was done. If it's a 3rd level, the station manager, the team, and the medical supervisor receive the alert, and they all have to report what they did with the mistake. And if it's a 4-level, meaning it's a very severe alert, for example, if you gave a wrong medicine to a patient, that will be a 4-level alert. Then it goes up to the division manager, and everybody has to reply. Looking at the digital and electronic tools, as I said, so we have online monitoring. So every ambulance monitor is displayed in the medical dispatch, and we have an alerting system which we created the barriers for example, if somebody is had a low blood pressure, as you can see on the screen on the right corner, the square of the ambulance turns red and it's blinking. So the medical dispatch center sees that something is wrong with that patient. So even if the team didn't notice that something is wrong, the medical dispatch call center can see it and they can call the team and or support them during the treatment. For receiving calls, we have all the calls are recorded and analyzed by the quality assurance guy within the dispatch center. All of our devices are reporting, and the data is transmitted live to our servers. So if it's the ALS monitors, we use Corpus. So we have the Corpus server, and then they can also be supported, but monitored as well. And if it's the AEDs, the AED data is sent automatically to a folder in our system, and you can analyze it. And every, I would say, few months, we analyze probably few dozens of CPRs, and then we issue or write about our conclusion regarding and the quality of the CPR. And I would say recently, but I think it's already running for 2 years, since Israel doesn't have an out-of-hospital cardiac arrest national registry, and since it's something that it's very valuable in our eyes, and you can learn a lot about it. And the last time we tried to research about this field, it took us 1.5 years. What we did is created a digital registry when the teams are putting up the suspected diagnosis. So if it's cardiac arrest, they can't proceed filling up the form without filling up the out-of-hospital cardiac arrest registry, which we created. It doesn't show up at the patient report at the end, but it's something that the data we collected, it's built upon the Utstein criteria. And then we can learn, and we already did learn a lot from it. And actually, few things we implemented lately, we already know that we need to change a little bit our guidelines regarding it. Field audits. So in addition, we also conduct field audits. We have the CEO audit, which is a monthly audit, and then representative from every management department in the organization. We go to a region and then we do an audit, each one in his field. The supervisors themselves need to do regional audits within their region. As was presented before, we see the teams, we talk to the team, we do a knowledge test to the teams. Another thing that the regional supervisors do is a peer audit. So every month they need to go to a different region and then they do peer audits to their peers or teams for the other regions. Our medical directors also conduct regional audits and join us for the other audits. And as you can see, there's an example of specific audits that we do according to an event or situation. Another thing we built is it's called the manager dashboard. So it reflects every region managers the results of every aspect that is measured in his region within a screen that they can see it with graphs and see where they're standing in everything from training staff, quality assurance, KPIs, and so on. So it's something that they can see, and they can see how they are referring to other regions and to the country average as well. And lastly, something I discussed about it earlier, I think in an earlier session we had, but technical barriers is something that I personally I like a lot. So we have KPIs measured throughout the health system in Israel. And you can see the KPIs here. It's for CVA, for the fast assessment and the hospital alert, for ACS, giving the patient aspirin and transmitting an ECG if it's an MI to directly to the cath lab. If an advanced airway was placed, then we need to see 3 consecutive measurement of end-tidal CO2. For out-of-hospital cardiac arrest, we measure dispatcher-assisted CPR, ROSC rate, and survival to ED. For sepsis, we measure Q-SOFA and hospital alert for patient with Q-SOFA above 2, and pain management. So all of those are measured. And what we did, since we want to measure them, and we enter the screen within the medical record that they fill up. Again, it's not something that you see at the end on the paper that the patient gets, but it's something we measure, and we send it to the Ministry of Health. So they have to, they have to fill up those screens. And if they don't fill up those screens, they can continue filling up the forms. And what we found out that those screens are a valuable teaching tool. Since they have to report, then they learn about the fast, they learn about the condition within you can give or not, or you're not allowed to give aspirin and so on. So it's another measurement and a teaching tool that we use. And that will be it.
Thank you very much, Tomer. And this is it. We have all the 4 speakers. So anyone stays around, so please get your questions, raise your hand if you want to come over to discussion. Please. You can get some questions for any of the 4 speakers. If not, I think this is it. And we will close the session and this opportunity once again. Thank you very much. Michelle, are you doing anything? Do you want to share anything?
No, I just want us to stop Tomer sharing without anybody acknowledging it.
Okay.
Sorry.
Okay, no problem. Okay, so there's no questions. I have the chat, I have Q&A. So we're going to end this. Once again, thank you very much, Ândrea. Thank you very much, Paloma, Joana, and Tomer, for your presence and for sharing all these good things that you came to us. Once again, thank you all for your time. Remember that we'll have our next and last webinar from KnowEMS projects at 11th December. Once again, so I think we'll be all together for one last time on December 11. Thank you very much for all.